Professor Sarah Abraham, who's a senior professor and the head of the Paediatrics Unit 1 in the Department of Paediatrics at Christian Medical College in Vellore, India. So Professor Abraham completed her training in paediatrics in 1998 and after a tenure in private and mission hospitals, joined as faculty at the Department of Paediatrics in Christian Medical College in 2003. In 2009, she completed a 3-year clinical fellowship and PhD in paediatric endocrinology from the Liggins Institute in Auckland, New Zealand. Currently, she's a clinician, teacher and researcher in paediatrics as well as paediatric oncology at CMC Vellore. Thanks very much.
Thank you very much. I am actually the last speaker of the day, and we are 1.5 hours through lunch, and I hope I don't really put you to sleep. And at the outset, I would like to thank Professor Roy Joseph and the entire organizing team for inviting us here and giving us an excellent hospitality over the last couple of days. I bring greetings from the Christian Medical College Department of Pediatrics, and this is the Women's and Children's block where I work. Over the next 20 minutes, I briefly have a couple of slides on our institution's model of subsidized treatment for needy patients, bring about some case scenarios, and then summarize the talk. The Christian Medical College is exclusively a private institution attached to a medical college, and it's one of the largest tertiary care centers in India. Despite being a private institution, we generate funds for giving a large number of subsidized care for the needy patients. And where do these funds come from? The main source is Friends of Vellore. These are alumnus as well as well-wishers of CMC from different parts of the world. As far as I know, there are 6 Friends of Vellore teams which provide money for the subsidized treatment for our needy patients. And then there is a scheme called Person to Person, the PTP, which originated in Germany and subsequently now 3 or 4 other countries also we have donors. Essentially, they contribute to the treatment of one individual patient. When a large number of people are involved, it does contribute to treatment of a large number of people. And individual donors in small and big ways, people who have been satisfied with the treatment, they might donate to the one cause, like the treatment of one elderly woman or the treatment of one patient who was born on our Founders' Day and things like that. Of course, we have some coming from the corporate social responsibility of the public sector units and some of the corporates. And in fact, we have private as well as general patients. Everybody who pays the whole bill, a small percentage of it goes into our charity pool. And what do we do with this money? And it's important to remember that we don't have any crowdfunding platforms. So this goes to the subsidized care. So patients who come to CMC belong to all socioeconomic strata, and they may pay 100% of the bill, but they may pay 0% or anywhere in between, based on the need. Not every patient who needs have these resources. So subsidies in terms of medicine, investigations, inpatient bill, and we have one of the most subsidized undergraduate education, even compared to the government colleges. And there are some scholarship programs and outreach programs among the villages and the tribal population. And not particularly from this fund, but CMC has its policy of supporting treatment for its own staff and staff dependents. Now, I have put an arrow directing to both sides, and this was done purposely. So these funds provide subsidized care, but it's the subsidized care as well as the education and the research in CMC which actually are the biggest incentives for our donors. So it works both ways. Of course, there are limitations of funds. Forever, we have more patients in need than supply. And resources are used for all those in need, not just those who are financially poor. We have a large number of patients who come from several thousands of kilometers away, primarily having spent a lot of money and resources on diagnosis with complex conditions, difficult diagnosis. Some of them are from middle class or even upper class. For specific diagnostic tests or specific treatment, we do support their care. And it's also unique that the subsidies are entirely decided by the treating team. We don't have any social workers to assess the socioeconomic status. And we do rely a lot on our interns and residents who actually are in charge of each of these patients. So after each rounds, we do ask them what is the socioeconomic background of these people who deserve treatment. And very rarely, we need to involve the administrative head of the institution. With this background, I'll start with case scenarios. A 1.5-year-old child was brought by mother to neurosurgery OPD. MRI film from elsewhere showed a large brain tumor. The tumor was deemed inoperable, and the team advised to take the child home. Child was well preserved at that time. Few hours later, the child was brought gasping to the pediatric ED by the mother. The on-call the pediatric resident, immediately intubated and started bagging. The neurosurgery resident subsequently came in, suggested extubation and discharge home as the tumor was inoperable. However, the pediatric resident saw the mother's agony, informed the pediatric consultant on call, and shifted to PICU and connected to ventilator. So this child was admitted as a free patient under pediatrics. Hospital-free diet was arranged for the mother. In fact, there was no one with the mother, and she had traveled from the northeastern part of India, almost 2,000 kilometers away. She just had a cloth bag with her, and from a telephone number on that cloth bag, we actually contacted one of the family members. This was one of the shops nearby her home. 3 days later, the child passed away. Hospital helped with the afterlife care. Mother was shattered, but she was able to cope. Finally, she went home with a family member who managed to reach Vellore in the next 3 days. So this child was from 2,000 kilometers away from Vellore, and the only relative was an illiterate mother with no money even for food. And there were 2 points of view from the decision makers. The first doctor thought, yes, it's an inoperable tumor. There's no support system in terms of finances or manpower. Let nature takes its course. And the second doctor thought, yes, it's an inoperable tumor. He's not offering support for treatment, but the support for the mother who has traveled 2,000 kilometers in search of medical help. So the mother needs support to come to terms with it. In the first case, science alone, whereas in the second case, science, empathy, a lot of core values, putting ourselves in the another's shoes and experiencing the same pain and agony. And so what does the moral courage of this pediatric resident achieve? Mother had some time to come to terms with the seriousness of her child's condition. All of us pediatricians face this all the time. Very often, even though the mother had this MRI film, no one had really explained to her, because to her the child was actually awake, alert, feeding, and she had not understood the seriousness of the child's condition. So very often the parents are in this condition, and mother felt satisfied that her child received treatment at CMC. This was a fervent hope when she got into an unreserved compartment and started her a long train journey. And mother does not have to live with the guilt of thinking, if only I had taken my child to hospital earlier. All of us who are familiar with counseling terminally ill children always remember, we need to remember this. The parents should never be told, okay, you came too late, because they live with this guilt. We must make them feel that they have done the best for their child. And of course, a family member could be with the mother to share her grief. Medical knowledge and skills should be laced with empathy. Moving on to the second scenario, this was a 2-year-old son of one of our staff. He had recurrent seizures from 5 months of age, diagnosed to have West syndrome with global developmental delay, and the only developmental milestone he has achieved is partial head control. He had 5 previous admissions for intractable seizures. Currently, this is the 6th admission with an aspiration pneumonia. He was admitted in PICU, developed complications, sepsis, shock, and got intubated, and had a very stormy course in the PICU. Multiple counseling sessions were done with the family, that all possible treatment is being done. Once again, we have the system where the children are admitted to the PICU team, which is primarily involved with the treatment of the child. But again, the child has a parent admitting unit, pediatric unit, which deals with all the financial support. So the parent unit ensured full support for ongoing treatment with approval from the administrative head, because We are not allowed to use any of the hospital charity funds for staff or staff dependents. There are earmarked definite criteria for their treatment, and investigations and the inpatient bill are free, but there is a ceiling on the pharmacy drugs. This particular father was already paying a lot of installments because of the 5 previous admissions and large bills, and so was taking home a small salary. Eventually, the child passed away on ventilator. 2 weeks later, the father was called in for a meeting in the administrator's office, and an option was given to decide the amount of the pending bill which he could pay after deducting all the staff dependent benefits. And this was a small amount, but he was given permission to pay this in 50 installments almost. This was an unheard of number of installments. And of course, the buck did not stop with the administrator. He had to explain this to the administrative committee and a lot of other people, but that is what was done ultimately. So the moral courage shown by this administrator, what did it achieve? A huge relief for the young father. There was already a lot of friction with the wife and in-laws because the antenatal care was done at the mother's house, and for the first 5 months, the seizures were not actually picked up, identified, and therefore there was already a lot of friction between the in-laws and the wife. And they also gave hope to plan for another child in future for this young family. And it reassured all category of staff in the hospital that the best possible treatment will be given irrespective of their ability to pay. And it did not set a precedent for writing off staff-dependent bills. This again would have created a huge problem for the hospital if all the staff and the staff dependents expected this certainly will be a burden for the hospital. So this was also not done. So good rapport and frequent communication vital in convincing families with sick children that the best possible treatment is being provided to their little ones at all stages, and whatever decisions we take, I think it's really important to communicate with the family. Moving on to the third scenario, it was an 8-month-old infant with polyuria and polydipsia was admitted. Over the next 4 days, the serum sodium remained above 200. This was one of the very few children whom we had with sodium levels above 200. Despite all efforts, parents had lost their first child to similar illness. Extensive counseling and good rapport was built up with the family, with the treating team literally with the family round the clock. Parents had agreed on genetic testing. Sample was collected and stored during a routine sampling. Child passed away after 4 days. The parents were very agitated after the child passed away and refused to give consent for genetic testing. The cremation was done at Vellore with the help of our afterlife care services. 4 days later, surprisingly, father came alone to our office and on his own signed consent for the genetic test. The report came as nephrogenic diabetes insipidus. Parents were informed. Once again, these parents were very far away. They were informed over telephone. And 6 months later, we were surprised to see the parents had traveled another close to 3,000 kilometers once again to meet the treating team of doctors. Grateful for all that was done for the child, and they underwent genetic counseling. We have to have the courage to counsel parents even during grief and bereavement. As was mentioned by the previous speakers, one of the previous speakers, very often when we take an informed consent, it doesn't really mean that they understand, especially when their child is critically ill. They understand very little of what we actually explain to them. So parents often cannot think right or take a right decision when their child is critically ill. So we need to use our ability and knowledge to help them. And it's a fact that the kindness shown by the doctors and nurses while dealing with critically ill children, whatever be the outcome, often help families make sense of their suffering and loss that they experience, sometimes even years later. Coming to the last scenario, this was a 28-day-old baby from an orphanage nearby, weighing 1.8 kg, with multiple congenital anomalies, severe micrognathia and mandibular hypoplasia, incomplete cleft palate. She had bilateral hip and bilateral knee dislocation and doubtful congenital heart disease, atrial septal defect. Actually, at during antenatal period, because of the severe retornathia, this child underwent amniocentesis, The mother underwent amniocentesis, and the family was advised medical termination of pregnancy, but the parents decided against it, continued with the pregnancy. Baby was born at 36 weeks by an emergency LSCS, and baby was on CPAP because of respiratory distress for the first 4 days. Subsequently, when stable, they took the baby against medical advice and had handed over to the Child Welfare Center. And the orphanage, the only orphanage in our Tamil Nadu, which deals with children with special needs, agreed to take this child. And this child was brought to us at 20 days of age with severe respiratory distress and hypoglycemia. There were major issues with the airway. There was no chin for this child actually to fix any tube. Difficulty with the IV access, with feeds, and developed hospital-acquired infection, septic shock, and respiratory support was upgraded to nasopharyngeal CPAP. Over the next few days, the 3 times downgrading NP-CPAP was failed. On a Saturday morning, the hospital ethics board called for an emergency meeting because the PICU team was very worried about the airway, and they thought this baby may need intubation over the weekend. And this was a very wise decision because this did not leave the matter to the junior-most doctor who was on the floor to take a decision on a weekend. I think it's really important for us to remember that the junior doctors, the very clear instructions have to be given to junior doctors of the team. So what was discussed in the ethics board? What were the life-threatening conditions in this child versus the non-life-threatening deformities? What was the quality of this life, quality of life long-term for this child? If after discharge we send the baby to the orphanage, whether the orphanage has trained nurses for ongoing care, whether they have funds for ongoing care after discharge. The financial burden to the hospital for providing free treatment to this baby was not discussed. So opinion once again was taken from the pediatric unit team which admitted the baby, and the team unanimously thought that in our experience while counseling parents at similar critical juncture, we have seen that parents never give up. So this was one of the big incentives for our hospital ethics board to take their decision on non-escalation of treatment, at least we reached there, which means all treatment short of intubation to be continued. The legal guardian, who was the orphanage in charge, was counseled, and a written consent was obtained for non-escalation. But to our great surprise and happiness, the baby steadily improved. 15 days later, was discharged to the orphanage on nasogastric feeds, and a large bill of 600,000, that is 6 lakh Indian rupees, was written off. But I must say that last week the baby returned for a review with a good weight gain and tolerating nasogastric feeds well. So the courage to act in the best interest of the patient in the midst of uncertainties. We have heard lots about it, the best interest. But I think all these ethical dilemmas are because of the uncertainties. We are uncertain about the diagnosis sometimes. We are uncertain about the effectiveness of a specific treatment. We are uncertain what exactly the parents want, whether it's quality of life or longevity of life. There are so many uncertainties. So what was the advocacy for this baby? The life-threatening issues were airway, overwhelming sepsis. However, most of the congenital deformities were correctable over a period of time. So why not provide a second chance to live if we have a role in decision making? The long-term outcome is certainly uncertain, length of life versus quality of life, but should that stop us from treating the current acute illness? When unsure about future sequelae, honor the divine principle of the sanctity of life. So, in way of concluding, it's important to discuss the ethical principle in our regular team meetings, with all team members being allowed to openly discuss their views. And we should be willing to listen and accept opinions from peoples at all levels, from the youngest to the oldest. And it's very important for good ethical practice that there are approachable seniors who can take a final call on whether to intubate the child, whether to admit the child is free or partially funded, whatever. And we need to learn from past experience. That is truly our experience of the department, that we have always learned from our past experience. And role models can develop at any levels, and institutional policies must be in place that support ethical and good clinical practice. So, to summarize, when decision making becomes difficult, discuss. Collective wisdom is always better. Train people at all levels to have the courage to do the right thing, and always have the best interest of the patient in mind while using the simplest intervention to the most cutting edge technology. And stand up for what is right, even if you stand alone. And I also have a disclaimer. My talk is purely based on phronesis, that is practical wisdom, passed on from generations of our seniors and I learned a lot from my colleagues as well. And I am leaving behind more questions than answers, even when resources are limited, which is a story for all of us. We often hear maybe we have to limit the use of expensive technology like ECMO to only those who can afford. However, if using ECMO technology can save a child, can I put a price on his life? I would like to acknowledge CMC Vellore for giving us the freedom to use its charity and funds at our discretion for the needy patients, and the Department of Paediatrics, who for several generations have trained not just pediatricians, but people who care. This is the chapel of our institution, which is a very central point. And this is the 16th century Vellore fort, which is just about 10 minutes walk from our institution. And I welcome all of you to Vellore. Thank you.